So welcome everyone. Welcome for this third edition of the JOGL Live hosted by Just One Giant Lab. My name is Camille. I work as a program coordinator at JOGL and I'll be your host tonight. I'm very pleased to welcome our guests, Aku Sharia and Kimo Wong, and also Amish, who's part of the team, who are the leaders and team of a very new and fast-changing project called COVID-19 Rapid Action Patient Dispatch Solution. It is indeed an exciting time for them as they're refining their problem statement and their solution. At JOGL Live, we host projects independently of their stage of maturity because we believe that open collaboration is worthy at any stage. So for the ones who are not, I'm trying to, change slide, familiar with JOGL Lives, let me give you just a very, I see that my connection is not very stable, so feel free to interrupt me if you don't hear me well. JOGL Lives are 1-hour online events that aim to provide visibility to projects belonging to the JOGL community and foster collaboration around it in an open science framework. Just One Giant Lab, if you can still see my screen. So JOGL Lives are hosted by Just One Giant Lab, and Just One Giant Lab is a non-profit which acts as a research and innovative, open and massive collaboration platform. Our community is now composed of more than 4,000 researchers, engineers, data analysts, students from the globe, working hand in hand on more than 200 projects addressing the Sustainable Development Goals. If you need any more information, I'll send the links in the chat. You can visit jogl.io and the platform, the collaboration platform we have on app. Talking about SDG 2030 is to achieve universal health coverage, including access to quality essential healthcare services. So let me ask you a brief question. Actually, 2 questions. Among you, have you ever felt lost or not knowing where to go, which hospital to go, or which health center to go when you were sick or when you were having an emergency? And wherever you live in the world, have you ever reached a health center or health facility, and after you've reached, being sent to another one because they had not the right material, for instance, like a CT scan, or the doctor wasn't there, or because the waiting line was too long? So if your answer is yes to one of these questions, you're at the right place today. Because today we're going to talk about health. We're going to talk about how we can improve timely access to quality healthcare services. And we're also going to talk about mobile apps, technology, and data. And for that, I am very happy to have Aku Sharia and Kimo Wong here. So Aku is a software engineer who has worked across ad tech, CRM, crypto, and blockchain verticals for clients like Google, BlackRock, UNICEF, and startups. He teamed up with Kimo, who is a graduate student from McGill University with a background in biomedical sciences and experience as a project manager. They're going to tell you about their project, the COVID-19 Rapid Action Patient Dispatch Solution. And most importantly, they're going to tell you how you can help them. So we'll have a Q&A session. It could vary between, I would say, 10 to 20, 30 minutes, depending on how active you are. So you feel free to write your questions and comments in the chat. We will address them during the Q&A session. And during this Q&A, if you want to intervene, speak, feel free to do it by using the raise your hand button. It's in the participant section. So it's very open. Just keep in mind that it's very important to stay constructive and kind. So yeah, just be open. We can't wait to hear your stories. And I let the screen to Akul and Kumul, who's going to tell you about what they've been doing. Thank you again for being here with us. I can't wait to see what's going to JOGL Live. So Akul, yeah, I don't know who's going to pitch your project. If you want to share your screen, or if you'd like me to share the presentation, it's also okay.
Thanks, Camille. I think I'll take forward from here. So, hi guys, my name is Akul. I'm based out of India, and I've, like Camille already introduced me, I've worked across a couple of local startups here, working as a software engineer, and a couple of different verticals. So, like most of the people around the world, this unprecedented global pandemic has had some kind of impact in everyone's life. So let me begin with my presentation, if that's fine. So Camille, I'll just share my screen, and let me know if everyone can see that. All right.
It's working.
It's good. All right. So we are Project XCOV-19, and we help you navigate pandemics with ease. So what exactly it is, and I'd like to start with a story. So this is a couple from New Delhi, which is India's capital. And this is just for representational purposes, but the story is real. We have a pregnant lady who has been searching for hospitals that would take them in. And what they do is they go around looking for hospitals that would take them in. And they do this for 8 hours, approximately, 8 to 10 hours, spend their time. But none of the hospitals actually take them in because they're apprehensive that they might have COVID, they might have coronavirus, they might be positive, but they don't have the proof for it. They have not done the testing, and it's an emergency situation. Most of the hospitals have denied entry. The ones that might be taking them in have a long queue, or the ER is full. So in this case, neither the mom nor the baby made it. I have several such stories. One of them is from Bangalore, where another lady from not so well-to-do family actually delivered a baby in an auto rickshaw just in front of the hospital because the hospitals were not taking them in. We have heard many such stories from different states here in India, and it's not something that is very specific to just India. It's around the world. Like I've been hearing stories from Syria, from places in Pakistan. I'm hearing the same stories from Brazil. In fact, it's not just a situation in third world countries. It's also something that's happening in the States. I have many immigrant friends whose families have suffered. Some of my immigrant friends are from, again, like I mentioned, from some African countries, from Syria or from Russia, and they're staying in Germany, and they're telling me stories of the same thing that's been happening back at home. Some of my friends are from China, and everybody knows what happened over there. So the real question is that what really happens with such stories where you are denied access to basic healthcare and you're turned away because you have a long queue. There's a long queue of patients, and there are not enough beds. And the story actually started somewhere around March, when I started hearing about this in the news. And like everyone else, I started thinking, what if this is something that happens to me? And so it's kind of like a personal story where I'm trying to navigate through a prospective solution, and through a lot of refinements, trying to understand what is it that makes the hospitals overcapacitated. Is it the aspect of not enough treatment? So one aspect of the solution that I've seen JOGL and many such platforms is there's a solution of preventive healthcare. Then there's the treatment part of it. So a lot of projects are actually working on creating hardware, logistics, masks, ventilators. Then I started questioning the other aspect, which is, could it be a problem of management as well? So there are a lot of makeshift hospitals that are coming up, big stadiums, railway stations, even airports are being converted into big makeshift hospitals, quarantine zones. And how do you actually bring about the administration that happens in hospital premises outside to the stadiums or such makeshift quarantine zones, which may not even have basic healthcare infrastructure? But because of the population density, and India is one of the most populous nations out there, how do you manage the huge quantity of the high traffic of patient influx? So that's where we started discussing this idea, me and a couple of my friends, and we kind of talked to some of the people who are working on ground zero, like what exactly it is that people are actually facing. So that's how we came up with this solution. What we identified was a huge gap between what's being offered at high-end luxury hospitals, or something that people take for granted in first world countries, the massive healthcare infrastructure, the network that they have, and the patients that are actually stuck in pandemic zones not being able to get entry or admission. So the problem that we're solving over here is the problem of pre-admission, because of some kind of economic barriers. Either the healthcare systems are not able to adopt high-tech or low-tech solutions so that they can manage high volume of patient influx. If they have some kind of an emergency medical response system, maybe they take a lot of time for getting trained, and it's not a workable solution outdoors because situations are rapidly changing. It's kind of a dynamic situation. Sometimes you will have medical quarantine camps, and after 10 days or a month, they're gone. So how do you account for such dynamic situations? There might be existing solutions, but they're not really connected to ground zero reality. So ultimately what we get is a lot of patients dying, just waiting to get the treatment, just waiting to get admitted. So that's the kind of gap that we thought maybe we should look at. What exactly is the problem? So is it possible that we can offer a solution which they can start using from day zero, or maybe something that has a short training time, something that actually encompasses and involves all of the stakeholders, doctors, paramedic staff, the healthcare workers, on-field medical surveillance officers, and the patient, most importantly, because this is obviously about you and me and the normal people and helping the doctors out treat us. So if you could offer some kind of a unified dispatch and referral solution, which is flexible enough to integrate with existing solutions based on wherever it is that you're living, that's the kind of gap that we were trying to come up with. And the very first motive is that how do you find such hospitals? So I know about 911 in North America, and I know about similar systems that kind of makeshift solutions that have been in place in other countries or emerging economies as well. In India, we have something that's called 108, but it's not as advanced, and we don't have enough trained paramedic staff or agents to actually handle automated 911 calls. So we kind of think of the solution as if you're someone who's actually in a city and looking for hospitals that will actually take you in, rather than going through Craigslist or a telephone directory, or some multi-specialty hospital that you're not sure of that would take you in. Why waste your time going to a place that might deny you entry? Just use your mobile, and wherever you are, we'll show you the available hospitals that have enough capacity, which may be beds, or it could be some other vector based on the assessment that we would provide you, which is very similar to how 911 is. Based on that, we would do some kind of a automated triage and filter out the available hospitals where you could be dispatched easily. Now, the dispatch could be either, think of it like Uber for healthcare, or you could choose to manually drive over there and check in. So we're kind of trying to save the time that you would have wasted if you had gone looking for such hospitals in a pandemic zone where none of the hospitals that you're looking for are actually providing you with admission. This way, we can actually diversify the flow of patients, and it would be much better for them based on their assessment, whether they're looking for COVID treatment, whether they think they have COVID-like symptoms, or if they have some other emergencies. And most of the hospitals near you are actually just taking in COVID patients, then which is the right hospital for you to go to, or which hospital may refer you to the right place. That's the kind of solution that we're coming up in 3 steps. So the number 1 is that we register you on the solution. The step 3 is that the step 2 is that you basically look for the available hospitals based on the assessment. And the next step is that you get dispatched. And all of this is right here on your mobile. Just like you would use Uber, you could probably use this solution to check in yourself into the hospital. So my question is, if you've ever visited any of the third world countries, because the solution that I came up with is kind of keeping emerging countries in mind, which don't have a scalable, strong healthcare infrastructure. So if you've ever been in any such country, including India, and you've felt some kind of medical distress, how do you check in yourself? Would I find such an app useful? I think so. So that's the kind of solution that we thought might help visitors, tourists, or people living in metros who are not able to navigate through medical facilities where to check themselves in, come up with a centralized app. And that's our 3-phased solution for helping the patients with the hospital. So this is one part of the solution, which is consumer focused. But the other part is providing the accessibility and pre-admission integrated solution for the medical care facilities. It could be hospitals, or it could be makeshift hospitals or quarantine zones, because I understand that COVID is a global pandemic, but usually somewhere around the world, there's always an epidemic going on. So this is a solution for all such kinds of diseases. And if you're in a region where you're stuck, this is the kind of solution that we're trying to research and come up. And we're moving very fast with this dialogue with the intended audience, how this should help them. And this is a good start for us, because in the last 1.5 months, we have kind of rapidly pivoted, maybe faster than a chameleon shapeshifts. So basically, it's here to help people like us get to the right place, help the doctors go through the treatment, get the diagnosis done, get the electronic health record, so that you don't have to carry your own medical files. And wherever you are in the world, you should be able to just check in, and your diagnosis and admission should be very fast. What we think that the advantages of such a solution is that patients are always informed wherever they are. It becomes easy for the paramedic team, for the dispatch team to synchronize between the hospitals. If there's some kind of a referral needed for the patients, it saves them time. Instead of going through multiple hospitals, they can go through just one. And that's the kind of solution that can help minimize a huge volume of patient influx, reduce the patient queue time, get a lot of these moving parts automated. Yeah, and then basically that's it. I think I've spoken enough, but Amish, do you want to like dive into some of these aspects?
Absolutely. Thanks, Akul. Hi, everyone. My name is Amish Chadha. I'm a managing director with Design Molecule, product innovation and operations leader. And I've worked in the field of, well, worked with clients and organizations in the healthcare space for several years now. And I was brought into the team. I'm with JOGL. I'm with Healthful Engineering, which is a parallel sister organization as well. And Camille had introduced me to Akul to help them along. And it's been exciting to see the problem space that they've been trying to address here. Some things for context, and I know Akul talked about emerging markets, and that's really important to keep at the back of your mind when you're looking at how COVID has spread and the challenges that it has wrought, not just on fairly developed economies and developed healthcare nations, but also what we're now beginning to see the influx of when we're talking about markets like India, markets like Asia, and so on and so forth, and the Middle East as well. Bottom line, I think nobody has ever been prepared for this. If you walk through a regular customer patient flow, what happens when you fall sick? You decide whether or not you're sick enough or you're feeling sick enough to go to the ER or go to the hospital. And your rubric for making that decision is often a very personal one. It's not often based on science. It's often based on gut feel. Some people are stronger than others. And one of the things that we have definitely seen in this pandemic is that ER numbers actually, in some places, got shorter and shorter because people were scared. People were actually afraid of going to the ER for fear of catching COVID because they knew that hospitals had become a hot zone. And that led to the question, well, if that is the case, how many things are people typically not going to the ER for where previously they would have? But what has influenced that decision? And there are lots of people that are very sick and are at home, but actually don't know where to go. If we look at a complex market like India, a few facts. India, by virtue of sheer population size, offers you a wide pool of available clinical data. Your hospital infrastructure straddles everything from your rural clinics, makeshift mud hut clinics that are being run by NGO doctors or doctors that do a lot of work pro bono and they have their own practices, and in many cases are not even reliant upon the industry standards around PPE. You hear horror stories about doctors that are forced, even in today's day and age in the 21st century, to go out there and boil needles or reuse needles. And we've seen vast cases of this in many third world countries and the disastrous consequences that are wrought from that. India has no unified emergency medical system. There's no unified medical referral system at all. So by contrast, if you were to compare this to a developed country like Canada, whereby once you are in a province or you are in the system, everything gets tied to your social security number or your social identification number. But if you were to go to one provincial hospital to the other, your medical records in the system is in the system. In a place like India, that is not the case. So when you have a problem and you do end up showing up at an ER, you have a bunch of different factors to consider and try to intelligently filter on your own, such as, well, am I a senior citizen or am I not? And if I'm a senior citizen, there is a different level of public health insurance that comes into play. Whether you have been a government employee, it's a scheme called CGS. And there's a list of certain hospitals that will accept CGS insurance. And the challenge with insurance, as everybody knows, is that there's always legal wrangling and wording that comes into play. So if a patient were to go to a CGS hospital, but not avail of the CGS insurance, or if they were to go to any non-CGS hospital because they felt that the level of care was better in this hospital versus a CGS hospital, they would effectively lose their insurance. So when you're a patient, the first point of call is, I feel sick. Do I need to go to the hospital? And what this solution is attempting to do is not to diagnose, and that's very critical here. This entire solution has no basis in trying to help diagnose a patient. It's trying to help patients make more expedient decisions on, number one, should they go? And if so, where is the closest available facility for them to go to based on the parameters that they are responding to? Now, one of the critical aspects of this solution is data privacy and the obvious aspects around HIPAA compliance. Anytime you're talking about any sort of application around healthcare, you have to make sure that patient information is sacrosanct. So too, do you have to ensure that any questions you're asking any potential customer or patient that is going to help them make such a decision aligns with what the medical services are actually doing. So when you go to an ER and you fill out a 2 or 3 page questionnaire, that isn't just a questionnaire that is prepared by a hospital. That is a questionnaire that is prepared by the legal team of a hospital, keeping in mind what the hospital's insurance liabilities would be. So any such questionnaire on this solution or this app would have to take that into account. But the critical factor here is once I fill that out and it tells me, okay, you know what, this is the information. Now, if you would like to go to the hospital, these are the various hospital locations available based on proximity, based on all the parameters that you've mentioned. And in some cases, it could be a hospital that is pretty far away from you. It could be something that is actually very close to you and a place you would have gone to anyway. The second component of this is, do you need an ambulance? Are you that seriously off that you need an ambulance? The challenge with ambulatory services in India is if you were to call a state number for an ambulance, you would likely get a van that shows up with 2 guys that are not trained paramedics, because the concept of trained paramedics does not exist in a country of India's size. The only locations that offer you trained paramedic services at a significant cost are the private hospitals. So when you actually contact them for an ambulance, you will be given a choice. Do you want a regular ambulance or do you want paramedic services? And there lies the fundamental crux of it. If you can partner with different hospitals, if you can partner with different government stakeholders, if you can partner with dispatch services or private dispatch companies, the idea is, can you take this information in its simplest form, PDF it, so that the dispatch company has an understanding of what your situation is before they arrive, the ER have that before you arrive, or when you eventually go to the hospital. Can you shorten your wait time to try and fill out a form if you can immediately share that information with the ER desk that has the responsibility of doing the basic triage, taking the sensory measurements of blood pressure, temperature, heartbeat, so on and so forth, and then helping you get through to the next stage, which is seeing an actual doctor or getting tested. Akul had mentioned earlier on as well that you've had makeshift hospitals show up in this pandemic, quite simply because no hospital has found themselves prepared. You can see how hospitals have had to deal with the initial issue of the disease has spread so rapidly and has progressed so horribly quick that people have landed up in ICU, and no hospital, no country plans hospital space or ICU beds with a view towards saying, you know what, we must have enough room for enough beds for every member of our population. It simply does not work like that. So if a patient has an idea that they may need a hospital bed, this allows them to understand which hospitals, if there's 2 options, which ones, if you do have to be admitted for whatever reason, may be a better route to take. You can't guarantee whether it would be a public room or whether it would be a private room, but at least you know, at least you have some comfort and sense of mind that there would be a hospital bed available for you should you need to avail of it. The other aspect here is the role of state and local governments. In a country as populous as India, one of the challenges that we've seen is huge migrant and daily wage migrant flow from state to state. A city like Delhi has a population of around 45 million. 20-something million people travel in and out of the city every day, or at least they did before the lockdown and before pandemic hit. Now, when you look at those numbers, many states around India, not all, but many states have begun to lock down their borders, which means that any medical services, any medical testing services would only be permitted for citizens or residents of a particular state. So consequently, we've had stadiums that have been converted. We've had railway services that have been converted. Nobody just lands up at a stadium or a railway service unless they're directed to do so by the government. So this is where a solution which allows a patient to say, you know what, based on the conditions we're seeing, based on the overloading capacity of hospitals, we're actually being directed to the closest stadium or to the closest makeshift hospice. That is where we need to go. Because the other factor that needs to be looked at is what is the actual availability of tests? And take in mind, different institutes and different organizations are taking varied approaches to how to do this. In some cases, you get tested, you go home, or you are sent home. In other cases, and certainly in the early stages of the pandemic, when they tested you, because it takes 72 hours to get the results of a PCR test or a COVID test, they actually said, stay in the facility if they had a bed available. And they increase the heightened risk of everything else that needs to go on. If you're a patient that suffers from autoimmune diseases, you're worried about your own insurance and you're worried about the hospital's ability to take you on as a patient, given their own medical legal liability for treating you as a patient. And this is a reality in most parts of the world. This isn't something that is just limited to India. But what you're seeing is the classic case of how bureaucracy hasn't kept up with the reality on ground of how agile you need to be and how quick you need to be. So this is a very much an intermediary solution where you're helping the patients do two things. Number one, I need to go to a hospital where it's the best possible location for me to go to, given my medical background, given my pre-existing conditions, given my demographic in society. Where can I go? And where would be the best place to go given the current crunch time of COVID? The second aspect is if I need to get help, if I need a dispatch service, who can I call? And can I do that through the app? And can I share any advanced information so that they can find me and they can be prepared when they come to pick me up? I think that is it from my end for now. And I'll pass it back over to you, Akul.
Thanks, Amish. I think that kind of covers the overall aspect of how end-to-end patient and hospital infrastructure synchronization that we want to do with this solution. We're not trying to get into the space of emergency medical response system just yet, because we see that that's a post-admission challenge. And that can only be addressed once we address the challenge of pre-admission. So we're going to stick to that. And this is kind of a product that is something that we're working very much right now. Our services go live this weekend. We're coming up with our solution, a very primitive prototype, if you will. I'll hand this over back to Camille. Camille, feel free to chime in.
Thank you so much for this very exhaustive presentation. And I can really weight the work you've been putting into that project by seeing it change and evolve and being more and more relevant to the problem you are trying to address. So congratulations on that. I would like to do two things now. Yes, please, everyone, if you'd like to check out the project website, Akul is sharing his screen right now. It's on it. And I will also provide you with all the links to contact the team if you'd like to make them some recommendation or suggest collaboration, start doing things together. I'd like to give everyone here the opportunity to provide their comments, feedback. You can do that two ways, either write it in the chat or use the raise your hand button, or just like turn on your camera if you'd like to speak. So that way I can just see you and know you want to comment on something. And So any question or feedback, just straight away. It's a safe place, so feel free to express. I'll give you a few minutes. And while doing that, while you, Dr. Ulwit says that it sounds like an innovative and excellent idea. So actually, Akul, could you tell a bit the audience, what would be a good outcome for you about this this meeting?
Sure.
Oh,
So,
okay, so yeah, maybe if you want to address
yep.
AD's questions on how you're going to get up-to-date information on the number of available beds.
Absolutely, that's a very good question, because with our first service, we are actually able to leverage on this data. Fortunately, a lot of countries have realized that by allowing hospitals and medical facilities to open up their data, it will help them solve the problem of this huge patient influx. Otherwise, what happens is, let's say in your city, you have St. Victoria or some other hospital, and that's all you know, or that's all you've ever gone to. So people kind of miss out some other hospitals that might have actually had available beds. In India, metropolitan cities are now under the direction of the Ministry of Healthcare and the state governments. They're opening up the data of private, public, and other quarantine zones. They're opening up the data about how many beds are available, how many beds are allocated by category, how many beds are actually occupied. For example, in India, with the service that we're coming up with, that will be, for now, it will be a web service. We're coming up with an app as well in the coming weeks. Bangalore, New Delhi, Pune, and Hyderabad are some of the big metros, like the biggest metros here in India, and they have opened up, their municipalities have opened the data. It's a circular that all the hospitals have to open up the data about the COVID beds that they have. And since this data is obviously available, the challenge is usually these kind of data format is not easy to navigate. So what we are acting as right now is we're starting out with an aggregation system. It's an aggregated platform. Think of it like Google Maps meets Uber. And that's it. You start off with wherever you are. And if your city has opened up the data about the available beds, it will be on our map. And it will tell you which of the hospitals are closest to you. Does that answer your question, Heidi? Great.
Thank you.
And we're trying to rally up this. We're reaching out to local volunteers here. I'm also in the coming days talking to several healthcare authorities, rallying on this idea that, hey, because these guys were able to open up their data, a lot of the patients were actually able to benefit from it. And that's a key marker for us. That's a turning point that we can rally on and communicate this to other cities, that if you can open up your data as well, the challenge is, how do you do that in a way that helps citizens navigate it? And that's where our healthcare-oriented service comes in, which is the second part of our entire product suite, which allows you to actually feed the data in a more segregated manner, in a more easily navigable way, so that it directly shows up on our app.
Thank you, Akul, for these
Correct.
answers. There are three questions that I'm going to read from Dr. Ulwit. The first one is, how do you go about management of data and data line concerns and security? The second one is, what options of access are available: USSD, app, web, call services. And I know this is something we have discussed together. The third one is how do you need to manage your round-robin service to ensure patients in need actually don't get routed the same center. And the fourth one, just coming up, how does this compare to other services like Practo already on this space?
All good questions. So this is unexpected wherever we go. The importance of data privacy comes in. So GDPR compliant, LGB compliant, HIPAA compliant, zero knowledge server data storage. These are the keywords if you're looking for, which means how do we deal with if the data ever gets leaked? So anyone who's a stakeholder with their own credentials, and that's something like the best practices by design that most of these HMIS or EMR solutions already have. So it's a given that we have to also come up with the same engineering principles. So our solution offers both HIPAA compliancy, and also the data is actually encrypted even before it's gone on stored on our servers. That's some of the ways we're actually trying to offer the solution, that how do you actually de-identify the patient data, who's actually accessing it. There's a whole system of running the HIPAA audit. Unfortunately, there's not an international body on how HIPAA regulations are managed globally, but we have some fair idea and some point of contacts, some experienced industry leaders who actually do this on a regular basis. So the whole design is built keeping this in mind. To the second question, the options of access are IVRS, not USSD yet. If there's demand for USSD, sure. There are some challenges with that. So USSD is, for those who don't know, it's I don't know if it's used in most of the first world countries, but it's actually like you press on your mobile with the key tap, and it's like a star, some number hash, and then you have options over there. So we are more inclined to start out with, because everybody has an Android app or an iPhone, but I doubt that the people who have iPhone actually would be needing the service. So Android users, people all over the, most of the places, even in Tier 3, Tier 4 backward regions, I've seen people use a mobile phone. If there's poor connectivity or no connectivity, no data connectivity, then we're offering interactive voice response system, which is IVRS, which means it's an automated dial-in. So whatever you can do through the app, you can do with the IVRS as well. It's also available as the web, yes. So the very first service that's coming up this weekend, it's a web service, because we are still in the process of coming up with an app and stuff. So yeah, call service, IVR service, that's the same thing. To the third problem, how do you manage your round robin service to ensure patients? All right, yeah, so this is the same, or maybe if you already know about the traveling salesman problem. So it's something like a modified traveling salesman problem, and it's based on the 911 kind of template. I was discussing this with Camille, and Camille also, she has experience in this background. So something that she mentioned is what we will be incorporating. It's the whole 911 assessment is based on some kind of decision tree. So based on the answers that you provide, you have a bunch of templates that we offer on the mobile service itself. And based on your questions, based on the answers, you're rerouted to those available hospitals. In short, that's like the very gist of how the service works. It's not that I'm explaining the algorithm. All right, there's some more questions. Okay, so Practo, I've briefly skimmed through it. I'm not aware if Practo actually offers pre-admission solutions yet. We have looked at other solutions like Epic, 75 Health, and many other indirect competitors in the EMR space. There are some other open source solutions as well, but by looking at the interface, I don't think it's the kind of solution that we can train existing staff and get it ready from day one. So the interface and the whole user experience is also of prime importance. Okay,
and I think there is a last question. Maybe I'll read this question out loud, and I think then we could shift towards, like, maybe Akul, you have questions for the audience. So let's answer this one and see like how people can help you actually. Dr. Owit is also asking, how is the integration between the app side patient registration to the hospital side? And then is it automatically managed or is it manually updated to the available healthcare center? And I think that's a challenge to be addressed.
I really don't think it's a challenge. I think one of the things that I forgot to mention is this is something new. Usually the solutions that are used, keeping the data privacy in mind, a lot of the solutions did not venture into the software as a service space because of what if the data leaks, and how do you address the problem of storing data on someone else's server if they sign a contract like a business associate. So like in the States, I understand that any healthcare solution provider, if they have signed a contract with a big search engine company, there have been news of data exploitation. So and that's the whole challenge that products in this space have not yet been able to kind of capitalize on the idea of being scalable by offering the service as a SaaS. In our case, we are offering the service as a SaaS, but with data privacy built in. And that's where the zero knowledge paradigm comes into play. How do we de-identify data and the stuff that is part of that design spec? Obviously, a lot of this information, because this project is open source, will be available pretty soon. So the integration part is pretty simple. We are offering both the services. It's running on the same cloud service. So it's a no-brainer for us. It's the same set of database that we're using. Is this automatically managed? Okay, what I understand is with the first prototype that we're coming up with, we have not yet tied up with public or private fleet of Medicare facilities or vans. Right now, with the service that we're coming up, it's pretty simple. We're just laying out the data that is already available. So once a suspect patient finds out that these are the nearest hospitals that have available space for admission in case they need it, and these are the hospitals available that are actually taking patients in, we let them decide which was the best hospital for them, because we're providing them with point of contact and the navigation, how to reach there fast on the map. It's pretty simple. In the future, like in future iterations, obviously the healthcare service itself, on, let's say, somebody who's actually on the kiosk, who sits representing while you're actually checking in, will be handling the B2B part of the product, and the patient app will actually connect with that. So all the hospitals will get the notification, and based on something like you mentioned, round robin. It's not exactly round robin that we're using over here. So based on the assessment and the number of hospitals that are available, ready to take you in, we will reroute you to the nearest hospital that you can be dispatched to. Or if the nearest hospital actually provides with the information that, no, this is not the hospital, maybe you should refer over there, we would provide you with the faster referral where you can check in.
Thanks, Akul, for your answer. And there is indeed a great opportunity for maybe a later integration with information system in place. That would be useful. One question to you: what can people here do to help you? Is there any needs you really have? Well, this is a rhetorical question, but yeah, to the audience, like how can people help you, and if they can help you, how can they reach you?
So we need, as far as the technical development aspect goes, there's a huge need for, if you are a UX designer, if you are a front-end developer, especially working on React, if you are someone who's a back-end developer, a software engineer, we have a bunch of voluntary openings. If you can give your time to this every week, because there's a lot of work to be done. It's one of the most complex engineering challenges that we're facing here. So there's always work. So if you work on, if you're a full stack developer, if you're a front end developer, if you're a UX developer, we need you as soon as possible.
I'm putting in the chat some links where you can reach out to the team.
Sure.
Okay, I just hope the links are working. So I'm chatting like the project page on JOGL. So remember, like JOGL is a free platform, open collaborative, so you can join the team on JOGL, but you can also directly contact them via email and via the website. Yes, so basically if you have ideas of networking, and if you know any UX UI developer, front-end developer, that would be amazing, and that would be a great help for the project. So Akul, would you like to say the last words? Maybe you want something, and I'll conclude and say, yeah.
Yeah. So obviously, first of all, thanks everyone whoever took out the time to actually hear our proposal out. Like most of the voluntary projects, we also are spacing in giving this enough time so that we can get back to normal. Fortunately or unfortunately, this pandemic has exposed a lot of gaps for people way older than me forgot to solve. So we are here trying to do that with the new tech, just like banking industry needed an upgrade. I think the healthcare industry has a huge potential. So yeah, feel free to ping us. My handle is Akul Matt on JOGL, and we are xcov19@googlegroups.com. Also our site, covidsos.net, has all the links if you want to reach us out further. Yeah, that's it. Amish, if you want to fill in, please chime in. Not sure if Amish can hear us.
Yeah, there is.
Hi, sorry guys, I was on mute. So, no, I would echo Akul's comments here, and thank you so much for everybody that has come back to us with questions, and by all means, please keep them coming. One thing I did want to add here is one of the areas where we will be looking to also collaborate even further with is the local and state government, because at the moment there's a lot of decision making around policy and diktats that are going out to the hospital network, such as where people should be getting tested versus where they shouldn't, because anything that you do around healthcare, we've talked about the data elements and the data side of things, but there's a huge impact on supply chain as well. So the state only gets so much by way of inventory with the PPE tests and the like, and they're being distributed to the various hospitals as well. So the solution needs to be as agile as possible, and we think that if we can get it presented to the state governments, then there is an opportunity here to do a pilot test with them. I know in some cases, some of the feedback we've received is that, well, some states have actually started to hit their peak. And I think if there's anything that we have seen so far in the last few weeks globally, you just do not know what you do not know. So you think you've hit a peak, and the reality is you haven't even hit a wave, and a second wave is coming. That much is a certainty. So, we're hopeful, and I'll leave it at that. Thank you.
Thank you. On a lighter note and more hopeful future, I want to thank you very much for being here tonight. We have a tradition of taking a group picture so that we can remember this great talk. So I'd like to ask you all to turn on your camera, and will do a screenshot of my screen, obviously. All right, Lillian, Lenny, we're waiting for you for 2 seconds, and otherwise I will consider, yeah, you don't want to. All right, counting to 3, say hi. So 1, 2, 3. Thank you very much, everyone. It was a pleasure to have you, Akul, Amish, and to have you all. So feel free to stay connected with JOGL, with the team. Yeah, it was a pleasure. We have another JOGL Live next week if you want to pop in. Yeah, just stay in touch. We are open and collaborative community. So I wish you all the best, and I tell you, like, see you soon. Bye-bye.
Thanks, everyone.
Thank you.
Thank you.
Thanks, everyone. Bye.